So I review the literature every year to see what's changed for this. And so the overwhelming point is that prevention of desaturations is where all the focus is. And it's really a frame shift if you think of we intubate because people are hypoxic, but really the frame shift is to fix the hypoxia with all your peri-intubation maneuvers before you intubate. And that's the way to do it most safely. And so also we're going to talk a bit about bougie and also something called delayed sequence intubation. Right. So think about this case as we go through. So this is one I took care of just a couple of months ago. So underlying airway compromise because of developmental disability, shocky, hard to pre-oxygenate and not improving despite our emergency department intervention. So we're going to go back to that case at the end to kind of wrap up some of the points. All right. So just remembering, and I show this every year, that what we do is dangerous. We've got great video review. This is one study, multiple studies that suggest we are not good at it as departments. There are lots of complications. It is not a safe procedure that we do. Right. And we also know that we need to maximize our first pass success. And so this is one of many studies that suggests that when things go bad, when you're not successful early on, complications rise quickly. Not only hypoxia, but you can see pneumothorax, all these things. And so it behooves us to prepare, go through all the steps to try to get this done correctly at the beginning because the complications multiply. All right. And this was really kind of the primary editorial after that previous paper was published, and that effectively said, you know, this is something we're supposed to be able to do. This is our life-saving procedure, and the data says we don't do it very well. So pediatric emergency fellows, you don't get that many opportunities. National data, 3.5 per year, and ask if that's enough to really master this competency. Our Airway database, which is self-report, we finally got the data. We only reported 42, 2016, 68, 2017. That is procedure notes that you complete. So 2 points to that, and is that complete the procedure notes, because I think we're undercounting. Our sense from many years of doing this is we're probably closer to 80. Or so. It's still not very many when you divide it by all of us. And also, when you're a fellow, and I'll emphasize this again, who perform an intubation, there should be a supervising attending with you. Please put them on the procedure notes so that can count because we're tracking this data for everyone. And so read this, and I'm not going to read it out loud to you, but please read it because I think this was the conclusion of that editorial. As you guys know, Steve Green's done a lot for our field, and you know, this was the challenge that he laid down with kind of this study and the other studies that have come down, is that we have to take every step we can to be the airway experts, and this talk is part of that. All right. So how safe are we? On healthcare, as you can see, we're the least safe when you look at safety data. And so if you look at the far left, what we do is not very safe. Compare that to the airline industry, which is very safe. I'm flying to Scotland this afternoon, so I'm glad the airline industry is at the lower right and it's not at the upper left. And so just realize healthcare overall is we are not very, very safe. So how did the airline industry become so safe? And they did that with lots of things, but checklist is one of the primary ones. So what is a checklist? So it's an organized set mind space so that all team members know what you're doing, that are used for rare, complicated, high-risk team-based events. Guess what? Intubation is the perfect example of that. All right? And I can tell you my review of the literature, the utilization of a checklist during rapid sequence intubation is rapidly becoming the standard of care and will be something that is really looked at critically when there are bad outcomes. Was a checklist being utilized? Right. And so with that, Marjorie and others, we've worked together to put together a checklist that is available, that we update. There's going to be a couple updates to it after this talk. That should be a standard part of every rapid sequence non-crash intubation that you do it. I can't say that enough. Even though you as a provider think you know what you're doing, your whole team doesn't know what you're doing. And you're not going to be as safe as you can be without having some type of shared mind space for the team. And the checklist is for that. So you have to get over kind of that hubris we have as the providers that know what we're doing and realize that we are leading a team and we have to involve the team. And the checklist is that, right? And not going to go through that in detail here. It's available. It's going to be even more available as we finish. So, all right. So let's go to when we do need to manage the airway. And you can have a whole list, but I like to look at it at 3 basic points. Is there a failure of airway maintenance, failure of ventilation, or we're anticipating that that is going to happen? And so, you know, the perfect one for the anticipated clinical course is the kid with septic shock. They always get worse. They might not need an airway right now, but it's safest to intubate them before they absolutely need an airway. So that's the anticipated clinical course, right? Right. And so we're talking about the lower left, going to RSI. Later this year, Marjorie's going to be talking about the other ones. Difficult airway, what do we do when we go down the difficult airway algorithm? Obviously, if they're dead when they come to you, they're unconscious, then that's a crash airway, right? So we're not talking about RSI in that setting. So we're talking about the overwhelming majority of patients that you're going to do a pharmaceutical facilitated intubation in a planned fashion, even if that is quickly. All right. You cannot intubate safely if you cannot bag safely. And in fact, we don't save people's lives with intubation. We save people's lives by being able to provide positive pressure ventilation. All right. That quote goes to Steve Baldwin. Nobody dies from the lack of an endotracheal tube. They might die because we can't ventilate them. All right. And so we have to shift from the mindset of, oh my gosh, they're difficult to ventilate, I've got to get a tube into place, to I have got to find a way to oxygenate and ventilate them so that I can safely get a tube into place. And realizing that not being able to bag is not an indication for immediate intubation. You've got to fix your bagging technique. And I mentioned cricoid a couple of times. So cricoid's not considered standard of care for any of the airway procedures we do. Some people do choose to bag with cricoid pressure, considered an elective thing when they bag. The data is not great on whether that really prevents gastric insufflation or not. So I don't teach people to bag with cricoid pressure. Some people do. I consider that kind of an optional thing if that is something you've learned to do, and we can talk about that in our skill sets. Next, right. Most common mistake we see is positioning mistakes, all right, is lining up the airway axes. And so the first thing you see people do is they put a neck roll under the neck that hyperextends. All right, and does not line up your airway axes. So just remembering you either need to be lifting the head or the thorax, all right, not typically doing a tremendous amount of hyperextension. And so remembering that is critical and focusing on that. So just remember where your towel needs to go. So kids, big heads, right? And so they tend to be hyperflexed and not lined up, so lifting up their body, right? That's a perfect example is there, right? And so the landmark is if you look at where the external auditory canal lines up to the sternal notch. It's kind of the axis you want to have. And so you look at the adult who oftentimes needs to have their head lifted up, not their body lifted up, right? And then we go to bagging, and you can go through the bagging slides pretty quickly, right? Because we'll practice as a skill set that we will practice in our skill sets, but the critical thing is that two-person bagging is almost always more effective than one-person bagging. And so going to that very quickly. Next. And so what you oftentimes see is this, and I don't know how many times you guys have witnessed this, is someone puts the bag on a face and pushes down, right? And you get what's on the left. And it is just the opposite. You are pulling a face up to your mask. is however you do your technique, you are pulling a face up to your mask to open the airway. And that's kind of really a mindset. And if you look at lots of people when they're first starting out, it's completely the opposite from what you tend to do, and it's putting the bag down on the face. You're pulling the face to the mask. So, remember to measure your right size mask. Remember when you're doing your sedations to make sure you have the right size mask in the room, because there's not. I'm going to go quickly through these. All right. Remember to have the right size bag. All right. So these little bitty bags are not going to work for a big kid. And so again, stuff you should be thinking about. Right. And so how do we maximize our bag valve masks? Our standard technique, reposition suction, quickly to two-person technique if you didn't start that way. Remembering that you have not failed bagging until you have oral and 2 nasal airways. All right, if they're not contraindicated, all right, and your pop-off valve is closed. So those little valves on the bags are set to pop off at 40, and we almost always, to establish an airway, need higher than that. So you need to close that pop-off valve, right? And that is a diagram of that, okay? So the rescue for failed bagging is better bagging, not in all cases, but in almost all cases, right? Next, right? So nasopharyngeal airway, and again, it's a skill that you just have to hold them and see. But from the tip of the nares to the tragus, contraindications to that, mid-facial fracture, newborn babies, they say, can be very helpful. We've all experienced what a nasal trumpet does. Next, oral pharyngeal airway from the corner of the mouth to the angle of the jaw. So if they're awake, it's not going to work really well because it's cause a gag reflex. But again, remember those adjuncts because they can be very, very helpful. Next, all right. So rapid sequence intubation. So simultaneously administering powerful paralytic and sedative, all right, without positive pressure ventilation if your patient can tolerate that. And that's the important thing. And I can tell you the majority of your team is not going to understand that. All right, the majority is not going to understand what a rapid sequence intubation is supposed to be. All right, so they have to have pre-oxygenation. They have to have apneic oxygenation, which we're going to focus on. And you want to avoid bagging until you need to. All right, it's a bolus administration. What I prefer to do is put the sedative, slam the paralytic, flush them both in together with as proximal IV as you have. It is a bolus administration, which means you're doing them at the same time. The drugs have to have roughly the same onset of action. All right? This is not a titration. Right? And the critical thing, and this is the thing that helps you the most, is the ability to use laryngeal manipulation when needed. All right? So bolus administration, powerful drugs, trying to avoid bagging. Why? Because that increases your risk of aspiration, stuff. Next. So also, and we talked more about wanting to avoid kind of the complications of pharmaceuticals and intubation that occurs with our sick patients. And I think critically, you need to tell your team what you are doing. You need to be announcing, am I doing a rapid sequence intubation? Am I doing a modified? Because this kid's already hypoxic and I can't fix it, or has increased ICP. So your team needs to know what you're doing. So being directive is critical. Right? So what is modified? So that's when we choose to bag before the ET tube has been in place. When do we do that? We're balancing the risk of theoretical risk of aspiration versus the known risk, right, of being hypoxic when you have increased ICP or whatever. So that is a decision by you as the leader of the team that you have to make that might change if they become hypoxic. But certainly would consider it a modified prospectively if I couldn't effectively pre-oxygenate them if they have marked increased ICP, already bradycardic. Next. Right. So delayed sequence intubation is a fairly newly described technique, mostly described in adults, but with some case reports in children, which is a technique for a kid that you cannot adequately prepare them for intubation. You cannot adequately pre-oxygenate them. And that might be because they are agitated, have significant developmental concerns, someone that you can't adequately pre-oxygenate. It's been described that typically with ketamine, so that you've done some mild dissociation, all right, will then allow you to pre-oxygenate and even use non-invasive positive pressure ventilation such as BiPAP and such, or even if you have to bag valve mask. And then you can give your paralytic once they're adequately pre-oxygenated. And that's now multiple case reports, primarily in the adult literature, of being effective, but also a couple of case reports of it weakening the respiratory drive to the point that all of a sudden you had to do a fairly rapid intubation. So you lost your ability to pre-oxygenate. So knowing that anytime you provide any type of sedative in someone in this setting, you could tilt them over the curve. Right. So when do we not use RSI? So full arrest, anticipated difficult airway, so severe obstruction, major facial trauma, distorted anatomy, then we might choose a different process. Right? Obviously, if they have no reflexes at all, they're totally obtunded, and maybe you might need to paralyze them, but you don't necessarily need a sedative, and you might already be bagging them already just to support them. So again, RSI is the most common thing we do, but there are times where we might not do it, and I'm going to say multiple times. The particularly dangerous for us is the kid in end-stage shock, where any drug, particularly the sedative, might be the thing that tilts them over and off the curve. All right? And so you have to know when to either use a decreased dose of the sedative or no sedative at all, because the paralytic allows us to intubate safely. The sedative allows us to intubate nicely, so you're not paralyzed and awake, but there might be times where you just have to err on safety. Fortunately, most of those kids, if you choose not to give a sedative, are so far into their shock state or whatever that they're not awake, alert in front of you. All right? So, take a second. So, think about how far we've come. All right? How far we've come. So, we avoid brutane whenever we can. Next. So, the 7 Ps used to be 8 Ps. So, the Airway course, which I highly recommend that everyone go to at some point, really, really helps with these skill sets. But what has happened is they've really de-emphasized the pre-medication portion. One of the P's used to be pre-medication and talking about lidocaine and fentanyl and all these things that might help us more safely intubate in certain clinical scenarios. And what they found is that pre-medication, no data to support it in most cases, and makes the sequence more complicated and oftentimes has unwanted side effects. So lidocaine is totally out. No one is recommending that anymore. Atropine is mostly gone, and fentanyl is moving away as well. They lumped a little bit of that into something we call pre-intubation optimization, and we'll talk a bit about that. So if you can go to our time sequence. So there's a time sequence. We're going to go through each one of those. So preparation. So most importantly with preparation is knowing when you need more help. Okay? So your evaluation for the difficult airway, but effectively the kids that primarily we look at and we see their syndrome and know we shouldn't be touching that airway by ourselves. And so I'm not going to focus on that. You need to know what your backup plan is going to be in mind. All right. You need to have everything prepared. All right, including your venous access and monitoring. So the important thing, and this gets into our code airway portion, is there's kind of two times. So I am getting ready to do a rapid sequence, but everything's fairly stable, but I might need more help. Right? Yeah, I'd really like anesthesia here to help direct it. So that is elective anesthesia call. Right? So the numbers are on the airway carts. Okay, how to contact them, also paging operator as well. So that is an elective anesthesia call. This is a decision you have to make, all right? Because then they might help you, might be willing to talk about awake techniques for this kid, different techniques, things such as that, all right? Obviously, our backup plan that we teach in our difficult airway is kind of cricothyrotomy, LMA for maintaining oxygenation and ventilation. So code airway. So, and literally this was a case that prompted me to work on a team to develop this. Is a kid that I should not have been intubating by myself at 2 in the morning and was extraordinarily lucky. And if I'd not been lucky, we'd be talking about something much different. But we developed a process, response team for the failed airway or the imminently failing airway. So it leaves for some judgment, right? This is a kid that's got a difficult airway that's going down the tubes quickly, right? And we obviously want to err on the side of protection of the kids, All right. When it gets cold, if you're directing your team, the operator needs to hear code airway and where it is. All right. Importantly, as part of bringing all this team members to the table, is we have to review them all. So, which is why all of y'all who have been involved in the code airway has heard from me, not because I'm judging your actions, because when it's part of our quality assurance for the process to make sure it's working like we want it to work. All right. So it involves the ENT, junior and senior. The ENT attending will not start in from home until they've heard from their resident. All right. I lost that little battle, but they won't until they've heard from the resident. The anesthesia attending will, and I think that's an important point. PICU and fellow and attending are typically in-house, at least one of them, and they respond as well. Okay, so how's it worked for us? Right. So we had 17 activations in our first year. The majority with us, all right, but PICU, CV, one on the floor, all right. 5 of them were canceled after, which I think is good, all right, because that means you saw it coming, all right, but fortunately you were able to attain the airway in a timely fashion. But I think it is critical to remember this, and it's one of our teaching points, that if you call a code airway and you all of a sudden get the airway, ask for it to be canceled. Okay, because there are at least some people starting in from home or other clinical situations. All right. Interestingly, 3 of the airways ended up being established in the OR, non-surgically, but with ENT in the OR for kids with such severe subglottic stenosis. And 2 of those was the same kid. So had same kid with 2 code airways. So anyway, and there were no surgical airways. So no one got their neck cut as part of this, which again I think is good as well too. All right. So the critical thing is for you is you do have to make that decision. Elective anesthesia. All right. So I'm worried about this. This might be difficult, so I'm going to get anesthesia to help me. Versus code airway that gets that multiple team member response with surgical capabilities. So let's stop for questions about that because I think this is critical. Does anyone have any questions about their code airway experience or how to utilize that?
Does anyone from here respond to code airways in other parts of the hospital?
We do not. We do not. So, so we don't. ER staff does not respond to anything outside of the ER for lots of reasons. So, except for the nursing staff, which is a different thing. All right. Other questions about code airway? So when we call a code airway, obviously I want you to err on the side of protection of the kid, but I will look at the case and kind of review it and see what we can learn from it. So don't let that dissuade you and don't get your feelings hurt when I say, hey, tell me about that code airway a couple days ago. Because myself and Nancy Toffel are actually on the pager response. And so we know when one's happening. So, all right, next. All right. So equipment. So anyone has their own mnemonic. For me, the critical thing that we tend to miss here is universal precautions. All right. Intubation is intimate secretion exposure. Think about that. All right. And many of those intimate secretions you might get exposed to are infected. All right. So there's no reason not to do face, mask, gown when you intubate. All right. Protect yourself first and foremost. The checklist goes over all this equipment, so it covers for some of this. The other thing is suction, because think about this, you can't fake suction, right? Can't fake suction. So, and I personally, you got it, right? I personally, with older kids, try to get 2 suctions set up because when you have chunks and stuff, your Yankauer gets clogged, and you need a Yankauer suction even in the babies. You know, you don't need a little flexible suction catheter. You need a rigid suction catheter even in the babies. All right. And then all your various other equipment and whatever. If you can have 2 IVs, that is great. If anyone's ever been in a rapid sequence intubation when the IV failed, we'll talk a little bit about that and how to handle that as well. All your monitors, stuff like that. And I'm good with questions, so if anyone has questions, don't hesitate to interrupt. So, all right. The video laryngoscope, what has that done for us? From a teacher perspective, it's been amazing, right? So it has been really amazing to be able to see what you're seeing and not trust. So we have improved glottic visualization. Probably takes longer to intubate with it. all right? Because the 3D skill of someone looking at a screen, it's just harder to pass a tube, and you see that over and over, all right? And there's some data that there's maybe increased initial intubation failures with it, all right? So we chose our video laryngoscope because you could be the type. We chose the CMAC because you can do DL. And so our preference is that the intubator do DL. So they're not looking at the screen, all right? They're doing DL with us. Us as supervisors can look at the screen. The other thing is it's changed how they recommend you should intubate. So anyone learn to put it in and pull back, right, till you find it. So now the catch term is progressive identification of the structures. So you need to start identifying every structure as you're going in, right? And in some team spaces in the literature, you're asked to call out the structures you're identifying, right? As a learning intubator, you're asked to call out tongue, epiglottis, and whatever. So progressive identification of the structures rather than the all the way in and pulling back piece of it. Does that make sense to you? So it's really changed that perspective, right? So ET tubes, quickly, in most cases we're using cuffed tubes. You need to know that their external diameter is a little larger, so it's a half size smaller. However you learn to size them, you need to accommodate for using cuff tubes in most of them. If you're using, as we recommend, our length-based tape for your equipment size, then it accounts for that. All right. Know that there's some cases where predicted that you might have subglottic stenosis or too small of airway where you might avoid a cuff like crew, right? And they only go down to size 3.0. Okay. So wrong sizing. All right. We've had at least one arytenoid avulsion here that at least in the review people thought it might have been the because the cuff had been checked, which we no longer recommend that. They used to teach that you check the cuff, you inflate it and deflate it, but then you lose your smooth, spiraled cuff configuration there. We don't know for sure why that occurred, but just know that, again, what we do is dangerous. And also know that the big risk is ongoing is subglottic stenosis. So part of our checklist in the post-intubation phase is for the RTs to check your cuff pressure. Right. Next. Right. Length-based resuscitation tape. We can't emphasize how much more accurately this has been shown for identifying equipment sizes and tube sizes and such. And so, please use it. It should be a standard part of what we're doing when we have a kid this sick. Pre-oxygenation, we're headed to kind of a change in how we're recommending this to some degree, primarily for the RTs. So what are you doing? You are filling your functional residual capacity with oxygen instead of nitrogen. It's our non-rebreather mask, 100% FiO2 masks are not, right? So at best on the way they're typically used, 50 to 60% because you entrain so much room air. There's now a fair amount of literature that suggests if a flush rate, so instead of the 15 liters, that they turned it on to a flush rate. So when the respiratory therapist hooked the non-rebreather mask up, they just turned it all the way up. Increases the FiO2 percentage significantly. All right. And so now I've been communicating with the head of RT now, and they think that we can adapt going to flush rate for our non-rebreather mask, right, for the pre-oxygenation phase. Question about that? Right. So if we obviously can't pre-oxygenate with just a non-rebreather mask, then if they're failed, we might be doing bag valve mask as part of the pre-oxygenation, or we might be doing CPAP, BiPAP, other things. So again, frame shift is if we cannot safely pre-oxygenate, then we cannot safely intubate. And so we should be thinking of fixing the pre-oxygenation in most cases, not all cases. There's obviously some exceptions, all right? So that's a frame shift, all right? And gone. Oh, go back one. The other thing is there's plenty of data now that we don't oxygenate most effectively laying down, all right? We oxygenate most effectively when we're more upright. All right, so the strong recommendation is half sitting position, or if you have to be flat, then reverse Trendelenburg of 20 to 30 degrees. Okay, there's also some recommendations that you actually intubate in those as well. I've never personally tried an intubation with someone half sitting. I have started to do some of those in reverse Trendelenburg, and it hasn't changed my ability to do that. So anyway, but certainly for the pre-oxygenation phase, you don't want them laying flat on their back. Right. Next, only physiologic curve you'll see from me. Right. Only physiologic curve. And just notice the very top curve, kind of healthy adults. All right. This is their oxygen saturations when they are apneic. All right, after they've been effectively pre-oxygenated. You've got all the time in the world, right? All right, you give them a paralytic, they quit breathing, go get a cup of coffee, come back 3 or 4 minutes later, can intubate them, right? Not our patients, ever. So our patients are much more to the left, okay? And so we have to work pretty hard to give healthily oxygenated minute of apneic time. Okay. The other thing, and this is absolutely critical, is when you start desaturating, right, you're gone. Right. So it's not 60% when you start thinking about bagging. It is 93%. Right. That is when you typically fall off the curve. Right. So it is 93% when you start doing bag valve mask and you convert your rapid sequence intubation to a modified rapid sequence intubation. Right. So biggest confusion that I want to clarify is the concept of apneic oxygenation. So something studied in adults with case reports in children, but has become the standard care with every protocol you read now for rapid sequence intubation. And that is continuous nasal cannula oxygenation during the apneic period. So the period from when you give your paralytic till when you put the tube in place. It's been shown that first pass success without hypoxemia, right, is much more common. All right. The key, and this is what people have confused and RTs have confused, this is not a pre-oxygenation phase. You have to put the nasal cannula on in place during pre-oxygenation. You don't have to turn it on. So some of the RTs that said, hey, we're hurting these kids by this awake kid getting all this oxygen blown up in their nose, right? So, and they're getting agitated and such. So the decision you have to make, your point is you've got to have this as a standard of care during your apneic period. Right? You have to put the prongs on before your apneic period during the preparation pre-oxygenation phase. It is okay if you turn the oxygen on if they tolerate it. Right? It is okay, but it is not mandatory. Right? So if they're obtunded, all the oxygen in the world is great. Right? But if they're a kid that's fighting, then you might choose not to turn the apneic oxygenation oxygen on until you're given your drugs. Does that make sense to everyone? Please ask for clarifications. But the point being to lessen the risk of desaturation during your apneic period, right? And so our checklist, did less than 5 liters, less than 10 liters, less than 15, greater than 15 liters. Also, some of the places do 1 liter per year of age up to a maximum of 15 and such. And this does not have to be your formal high flow nasal cannula. This can be any nasal cannula because it's short term. Obviously, if you've put them on high flow nasal cannula as part of your preparation phase and your other pre-oxygenation phase and peri-intubation optimization phase, it's great to use that. But it's a little too cumbersome for RTs to set up the high flow nasal cannula just for the purpose of apneic oxygenation. So we use a standard nasal cannula for that. Questions about that? So it has become the standard for this, right? Pre-intubation optimization, what we talked about. So framing it that you're not trying to fix the hypoxia with your intubation. You need to do everything you can to fix that before, all right, so that you can safely intubate. So that is BiPAP, CPAP, other things you might do. Know that if they're shocky, then your intubation drugs might worsen that. So if they need blood, fluids, or pressors, that's stuff, depending on your timing, that can be started before you intubate them. That is a decision. You just need to think about the environment. How do I make this kid safe as possible for intubation? Because more likely than not, at least transiently, my drugs and my intubation might destabilize this kid. So how do I make them safest? Some of the adult docs are still using fentanyl in the setting to decrease the catecholamine response on the heart. There's no real data for that in kids, and now several case reports of that causing profound hypotension and shock. So It's not something I use. Atropine is something that has kind of gone away. So the recommendations is if you're using succinylcholine, particularly if you're under the age of 5, and if you're repeating it, you can use it. Some people still choose to use atropine if you're really young and sick, if you're less than 1, if you've got pre-existing bradycardia, knowing that the bradycardia is more likely to be fixed by fixing their airway compromise and such. So atropine is not recommended as an intubation drug, but it is something that some people are still using. So that's your choice. So lidocaine's gone. Right? No one's recommending lidocaine usage in the setting of bronchospasm or increased ICP at this point. All right, let's chase after them and go. All right, paralysis. All right, we talked about that. All right, always with continuous apneic oxygenation. Next, unless you're doing modified. All right, quick thing on sedatives. All right, our 2 primary drugs are etomidate and ketamine. I'm not going to go through every point of that. We're going to talk about why not midazolam. It's a terrible intubation drug. All right, and when propofol is helpful. But etomidate and ketamine are the 2 big things in your armamentarium. All right, know that etomidate decreases corticosteroid production, and so there's now a recommendation to avoid that in the sepsis. All right. It also lowers the seizure threshold. Next. Ketamine, so we love it for bronchospasm. All right. There was this previous concern that it increases your ICP. That has not been borne out. And so now the recommendation is increased ICP is not a contraindication to ketamine. And in fact, for that combination of increased ICP, possibly shocky trauma patient, then ketamine might be the best drug in that setting. All right. Right. Propofol, so we all know that that's profound myocardial depressant, drops your blood pressure and such, but it's also a great anti-seizure drug. And so that it is one of the potential agents for kids in status epilepticus. So why not midazolam? So not reliable, delayed induction time, reliable doses get you into profound hypotension. All right, with a markedly prolonged duration of action. So if your paralytic's working at 45 seconds like you help your midazolam's working 3 minutes later, probably not real good. So ongoing sedation after you've intubated them, great drug, not a good intubation drug. Next. Paralytic agents. We really use 2, rocuronium and succinylcholine. Vecuronium is not a rapid sequence drug from an emergency department perspective, but can be utilized for ongoing paralysis. Next. So who has used succinylcholine in this room? Right. But a lot of people avoid it. All right. And why do we avoid it? Because it is associated with profound hyperkalemia in certain circumstances that can cause cardiac arrest. The things like crush, burns, it's a couple days before it happens, but any denervating neurologic condition, it can be associated with profound potassium release. And so our kids with CP and things like that might be at risk. So we tend to avoid it. But if you need someone to quit moving quickly, nothing works like succinylcholine. So it should be something in your armamentarium. So if you're talking about that laryngospasm after sedation, it works really quickly. And you'll still find that a lot of the rapid sequence protocols still list succinylcholine as the drug of choice. And you'll find, like the show of hands here, that most clinical providers use rocuronium as a drug of choice just because they are afraid of those side effects. And I'm actually okay with that. So the meta-analysis have suggested that clinically there's not a huge difference in intubating conditions, but rocuronium causes much more prolonged paralysis. And so that's the fear for everybody. But I've always felt that whether you're paralyzed for 8 minutes or you're paralyzed for 25 minutes, if you cannot provide bag valve mask ventilation in the setting of a paralyzed patient, you are toast. All right. So if you can't get yourself out of that, for me, whether they're just a little bit paralyzed or a long bit paralyzed, you're toast. All right. So what a lot of the recommendations are suggesting that if you have available, next, all right, the reversal agent, Sagamodex, known as Bridian, that rocuronium is appropriate. So we worked with pharmacy last year against a lot of resistance to try to get that in the ER. That was refused, but they supposedly are supposed to have it in their go bags now. So the task I have for all of y'all, next time you're intubating someone, ask the pharmacist if they have Sagamodex or Bridion. We need to confirm what pharmacy has told us. There's some anecdotal evidence that that might not be the case. All right. So to safely use rocuronium, I would say the standard now is going to be you need to have access to Sagamodex, so the reversal agent. All right. I've never used it. Has anyone in this room used it? No. All right. Positioning. All right, we talked about that. Continuous apneic oxygenation. Inline stabilization. All right. So front of the collar can come off as you give them their meds and stuff with reliable provider holding the head in line. Again, you're not doing traction, right? And again, sometimes you might decide to convert from a traditional RSI to a modified RSI and begin to do general bag valve mask ventilation, all right? Cricoid used to be recommended as part of that, otherwise known as the Selleck maneuver, where you identify the cricoid and push backwards. That was primarily used as a laryngeal manipulation maneuver, and so cricoid is not recommended as part of the RSI. It did not prevent aspiration and caused a fair amount of other problems. Next. So, once you've placed the tube, right, you've got to prove it. All right, how do we do that? So end-tidal CO2 detection is a standard, remembering that you can have some CO2 floating around. There might be a weakly positive on the first breath or two. So you really need to see that through 8 breaths to confirm that it's really positive, right? And knowing that they're in full arrest, you might not get end-tidal CO2, all right? I typically use 3 times the size of the tube at the lips. You guys might have your own formulas for that. RT might have their own formula for that, but be aware of that, okay? And know that your chest radiograph does not confirm endotracheal intubation, right? If you've confirmed your endotracheal intubation, the chest X-ray can show you where it is in the trachea, but it looks the same whether it's in the esophagus or the trachea, because sometimes they can be right behind each other. So just know that, end-tidal CO2, right? So this is what you want to see, right? We love that. This is what you don't want to see, all right? So my fifth grade sex education class, the movie was called Episcopal School, Hope is Not a Method, right? Hope is not a method for preventing pregnancy, and hope is not a method for getting an airway in that setting, right? So we need to be able to change that. How do we change that? Next, all right? External laryngeal manipulation. And if I can do anything particularly with our trainees, if you can leave our program with automatically with your right hand while you have that laryngoscope with your left hand, your right hand is on that patient's neck, putting that to work, then I would have done my job, because it can help us so much, right?
Bimanual laryngoscopy involves reaching around the patient's neck with your right hand and applying pressure on the thyroid cartilage. This simple and fast maneuver does 2 important things. First, the opposing forces of the blade tip and external manipulation drive the tip of the curved blade fully into the vallecula, causing effective epiglottis elevation. Second, it pushes the larynx backward into better alignment with the laryngoscopist's line of sight. Bimanual laryngoscopy, or ELM, is not cricoid pressure. Cricoid pressure is done by an assistant to prevent passive regurgitation of stomach contents in high-risk aspiration situations. Bimanual laryngoscopy is deliberately done to improve laryngeal view. The goal is first-pass success and avoiding episodes of bag mask ventilation. Fine movements of the blade tip at the vallecula and subtle changes in pressure and direction of force can cause dramatic differences in laryngeal exposure. Bimanual laryngoscopy is about connecting these fine movements at the anterior neck with direct observation of laryngeal view. After the view has been optimized by the laryngoscopist, an assistant can transiently maintain external manipulation at this location, freeing the laryngoscopist's right hand to place the tracheal tube.
So please make that a habit. Laryngoscope in your left hand, right hand on the neck. Right. It will help you so much. All right. Previously described, and that's kind of it, was what's known as the backwards, upward, rightward maneuver. So similar thing, hand on the trachea, backwards, upward, rightward. So, but anyway, it's moving it how you can see. All right. Questions about that? I think it's a critical point to safely next. All right. And then about that bougie. So interesting. Who's used a bougie for their intubations? Great, and I hope all of us can say we've done that. So there's now a great adult study that came out in JAMA that showed your first pass success in difficult airways, but they also had a subgroup that was non-difficult airways, which is much more likely with a bougie. All right, adult data. All right, but 96% versus 82%. All right, without any difference in attempt lengths or saturations. Okay, so how do we do that? Look at this.
So what's this thing right here? Well, it's my favorite Airway tool. It's the bougie. It's a lifesaver. Let me show you a few things you can do with the bougie. So let's take a moment to go over the basic or standard use of a bougie for establishing your airway. This one will require that you have an assistant or someone helping you out. We'll go ahead and insert our laryngoscope. Start identifying our anatomy as we progress through from teeth, tongue, there's his uvula. As I progress further, there's our epiglottis, and then we'll go ahead and engage the epiglottis. Take our bougie, have a good view of the vocal cords, and go ahead and pass the bougie. At this point, don't pull the laryngoscope out, leave it up in there. That way you can keep an eye on the anatomy and what's going on. We'll have our assistant or our partner go ahead and load up the ET tube. Now sometimes your tube will get caught up on the vocal cords or some of the other anatomy. Sometimes if you just kind of give it a little bit of a left turn, it'll work that bevel right between the vocal cords. And there we go. Now we can remove the laryngoscope, the bougie, go ahead and inflate your cuff, ventilate, and start doing your tube checks. Let me show you a quick technique using your bougie that eliminates the need for a partner or an assistant to load the ET tube up on it. We're going to preload. So you got your bougie, you got your ET tube, go ahead and put it on there. Now don't slide it all the way down to this tip. That kind of eliminates the whole advantage of using a bougie. So back it on up. Just have a little bit hanging out there, just enough to kind of get a grip on. Bring it around, and this is how you're going to hold your bougie and your ET tube. We'll use our laryngoscope, start identifying our anatomy, teeth, tongue, uvula. There's his epiglottis. I'll go ahead and engage the epiglottis. We have a good view of the vocal cords. We'll go ahead, pass our bougie, let go. And then at this point you go ahead and you can pass your ET tube.
Remember, we have an adult size and small size, and they work down to 4.0 tubes and such. Right. So bougies, so really something you should practice even in your non-difficult airways, just so you're comfortable with that. All right. So checklist talks about our post-intubation management and such. Cuff pressures need to be verified, gastric tube. The thing we miss most often is maintenance of ongoing paralysis and sedation. So we are using short-acting drugs, right? Etomidate, particularly in the setting of rocuronium, then you're going to be paralyzed and not sedated. And you typically will know that because of tachycardia, hypertension, and such. So automatic ongoing sedation in this setting unless contraindicated. The PICU is using primarily Versed and fentanyl for their ongoing sedation. I confirmed that with them. So probably as we try to seamlessly align our care, and it's a conversation you can have actually because you have time. And then vecuronium is a longer acting paralytic, and so if you have to paralyze them again, that's something that can be used. All right, but a study done in our institution suggested we're not very good at the ongoing sedation part, so just be aware of that. All right, deterioration after intubation. All right, so most often, this was a really sick kid and you just gave him a drug that caused cardiovascular collapse or the catecholamine release from your intubation attempts caused something going on. So again, the pre-intubation optimization, anticipating that, and I know some people verify that pharmacy has epi ready to go. We call it epi spritzer, for really sick kids. It's kind of a good idea. You have to have your own thing. And obviously, you also have your traditional dope mnemonic from dislodged tube pneumothorax equipment failure. So visualizing again, particularly in the days of the video laryngoscope and making sure that tube's in place is always a good idea. But just know that intubation, we take sick kids and we transiently make them sicker for a while, and you need to be prepared for that. Okay. All right. Failed airway, defined as 3 attempts by a senior person. All right. 2 scenarios. All right. One, you can maintain SATs with back valve mask ventilation. And I jokingly say you can go get a cup of coffee. You can't, right? But you can take a deep breath, all right, and say, what's next? Because I'm ventilating this kid. Again, they don't have to have a tube. They have to be able to ventilate and oxygenate. So you've got a little bit of time and you can figure that out. And that might mean calling a code airway. But the bottom one where you can't maintain SATs is obviously a code airway scenario. All right, so always going back to, it's not the tube you have to have effective ventilation and oxygenation and maximizing your chances for that. Right. So my keys to success, your checklist for your team, you need your whole team as the pilot of the team. You need to be very directive and assign roles, all right? And also understand that many people might not have done on your team any rapid sequence intubation. So if we talk about that year where we reported 44, how many nurses do we have here? How many nurses are in the department? 90. So it might be that a nurse has never done one, all right? Or not done one frequently. And you might have an RT that's not one of ours. So knowing that you have to educate your team, not just yourself. I like to bag myself initially. I like to know that I can establish the airway and comfortable with that, so I choose to do that. All right. You know, to always use a stylet with your tubes. All right. And also, again, this planning and knowing when someone more senior than you should be involved and might even should be doing the intubation is important. So asking for help. All right. You need a leader. All right. You need an intubator. So those probably should be separate for a little while. So you're intubating. So assigning someone else to kind of be leading the whole patient for a little while. All right. You need a medication administrator that needs to be designated. Your monitor watcher needs to be designated. You only want to hear from one person. You don't want 12 people in the room yelling at you, SAS 94, 93, 91, you know, and it's coming from everywhere. One person should be talking to you at the time. All right. Obviously, your cervical spine immobilizer. And the biggest challenge for us is the checklist runner. Right? Who is going to do that checklist for you? So my practice is if I'm doing an airway, I ask one of my colleagues to come in with me. If you're a fellow doing an airway, that's a great job for your supervising attending with them. They should be coming back with you. As fellows, you should be getting and attending every chance you get. And I know you're by yourself at 4 in the morning, so you might not be able to do that, but we're talking about perfect world with resources. All right. Trying to find someone who takes responsibility for that checklist is important. Yes?
Where are the checklists?
But they are on the airway carts, but as we've learned, like several things, they're kind of disappearing. So we're about to revise them and get a whole bunch more out.
Yesterday and the day I was
So they've disappeared. So anyway.
I'm going to put some there on Monday.
Right. Yeah. So anyway, so we're every year. One of the good things about this is we get to revisit what's working and what's not working. So, and we had noted that issue. All right, next. So this is a case where delayed sequence intubation technique worked wonderfully. His agitation, he was fighting his BiPAP and such, and so got him to the resuscitation room and gave him a mg per kg of ketamine, and all of a sudden we could maximize his pre-oxygenation. He tolerated his BiPAP. His SATs came up to 99%. We did that for 3 minutes, and we're able to do a traditional RSI on him without any desaturations. Much. So I put this case to kind of illustrate. This is kind of the case where you think outside the box a little bit. And so we had a failure of pre-oxygenation there, right? We could not prepare him to safely intubate him because, you know, in the 80s on BiPAP, what's going to happen as soon as you get his paralytic? Right, yeah, he's going to plummet, right? He's on the steep part of the curve and whatever. And so this is one where we were able to, with some ketamine, and 1 per kilo is what they say, but if he was really shocky, you know, and I thought at that point his shock had been, he was perfusing pretty well at that point, and I thought he could tolerate that, but if he was really shocky, he might choose 0.5 per kilo, you know, 0.3 per kilo. And so that's just a clinical decision, balancing the risk versus benefits. And so, but emphasizing the delayed sequence intubation, that really worked beautifully on this kid. Questions about that? All right, next, a couple more slides. Propofol, status epilepticus is great, but that's also a kid that you might already be doing modified on. They've had 4 doses of Ativan, they're no longer breathing, right? So you might just need a paralytic and continue to do your modified rapid sequence in that setting. Bronchospasm for ketamine, I actually like succinylcholine in the setting of bronchospasm because those are kids that you have a terrible time pre-oxygenating and maximizing that, right? You've got them on continuous nebs and your terbutaline drip and they're 89 and you give them their paralytic, you don't have much time, right? And we're obviously trying to avoid that. Some of those might do well with delayed sequence intubation if they're fighting their non-invasive positive pressure ventilation. A little ketamine and then succinylcholine, but you don't have a lot of time and you're asthmatic from paralysis to really markedly deteriorating parameters. Questions about medication selection? Right. So I want, again, to emphasize the point that sometimes you might have to intubate safely and omit or markedly decrease dose of your sedative. That is what tips people over. So you just really need to be aware of that. Right? Really need to be aware of that. So from a fellow's perspective on everyone's, Bernie's my puppy. Anyway, maximize your chances to practice this skill. Our fellows, please don't give your airways away. This is your chance to learn to do this. When you hang your shingle out, when you're done, we hope you're an airway expert. All right, so you need to practice doing that. Obviously, safely and balancing all those other things. So, intubate. Please use the checklist. Please. I know all of us who are senior here know how to intubate and know every step, but our team doesn't. All right, so please use the checklist to get a shared mind space for the team. All right, every study that's looked at it, and there's multiple now quality studies on safety of intubation, have utilized a checklist, and it's made a huge difference. So please use the checklist, all right? Please put your right hand to work. So same time, put your right hand to work. Do that, all right? Remember the dangers of sedatives, all right? And do your procedure notes so we know how many we're doing. And please include your attending in your procedure note, all right? So that they get some credit for it too.